Okay, so here we have a piece of tissue that doesn't look normal. It looks like it used to be subcutaneous and now has been replaced with a spindle cell proliferation. And kind of a general rule, if you're looking at something not from the retroperitoneum or internal body cavity, but if you're in the extremities, for example, or something that's been taken out by a dermatologist or a primary care doctor, if you see a nodule of spindle cells or of some sort of proliferation that doesn't have any dermis on it, doesn't have any epidermis on it and doesn't have any muscle with it, then you're probably at the level of the subcutaneous or maybe the fascia, because any proliferation in the subcutaneous or the fascia level is going to be easy to kind of pluck out without any other tissue coming with it. And if you have fat around it, even more so. So we're at the level of kind of the deep subcutaneous near the fascia, and I think we may even have we do have a little bit of skeletal muscle that came with it, so we're probably right at the very surface of the skeletal muscle on the fascial level. And you can see actually right here, this dense wavy stuff. A lot of times people say that wavy spindle cell areas in tissue are going to be nerve, but that's, I think, in my opinion, not true. Nerve is a little bit wavy, but if you have a wavy like this that looks like accordion, you know, like up and down real sharp waves with spindle cells and pink collagen, almost always that's going to be dense regular connective tissue, which means it's going to be tendon or fascia, or if you're near the bone, maybe ligament. So in this case, we're at the fascia level. So that's background fascia. But you can see it's not normal because it has a proliferation of cells around it. So let's go back to lower power for a minute here. And you can see there's this kind of hodgepodge, patchy infiltrate of plump cells and some spindle cells set in this very loose kind of pale blue mixoid or mucinous kind of background. And the little islands of fat are retained in here, okay? And instead of being a nodule, this process is kind of running in a line along the fascia, okay? And if you look at the spindled areas, the spindle cells look kind of spindled to stellate. And stellate means kind of triangle shaped, but people say star shaped, but I'm very literal and I think that stars should have like 5 points on them. So when we say stellate in tissue, it really means kind of more like pointy, triangular shaped looking cells. So if you have a good imagination, you can say they're kind of star shaped. So these kind of stellate to spindled cells in a loose mixoid background, that's a good feature for nodular fasciitis. And sometimes nodular fasciitis runs along the fascia in what we call the fascial pattern. It's kind of a linear pattern along the fascia, and it may branch and spread up into the subcutaneous. Like you see here, you can see it's going up along the septa into the subcutaneous. So this is kind of an unusual and uncommon pattern of nodular fasciitis. And if you haven't watched my video yet on nodular fasciitis, you may find that useful to watch before watching the rest of this current video. So this is a special subtype of fasciitis that is called proliferative fasciitis. And the reason we call this proliferative fasciitis is because of these large, funny looking cells in here. These cells, you can tell, are very big, kind of almost epithelioid, and they have a bunch of pink or light purple, amphiphilic we use for that word, that light purple kind of color, cytoplasm. And instead of having kind of spindled nuclei, they have big round nuclei. Now this slide's pretty old, so the stain is a little bit, the color has changed a little over time, but I'm going to see if we can still show you. These large cells sometimes have prominent nuclei like this. And they resemble ganglion cells from like the ganglia in the nervous system. And so people have called these ganglion-like cells. So when you see something that looks like nodular fasciitis but has variable amounts of these big epithelioid-looking ganglion-like cells with the huge nuclei that look like an eyeball staring back at you out of your microscope, then you can use the term proliferative fasciitis. And even though these look a lot more scary than regular examples of nodular fasciitis, they're still totally benign, and simple excision usually cures them, just like nodular fasciitis. So I think it's important to recognize this variant because it's easy to overdiagnose this as a sarcoma or some other malignancy. And particularly when you have nuclei like this, you can see, if you're probably not on the video, but at the scope I can see there's a little nucleus, or a big nucleolus right there, but the site of, or the nucleus is a little bit dark here and kind of blurring out that nucleolus, so it makes it hard to see. But the key is some of these individual cells, if you had them by themselves, like on a cytology specimen, for example, you'd say, gosh, that's probably going to be malignant. But a couple of things can help help you avoid making that mistake. Number one, there's a bunch of cytoplasm in these cells, a bunch of this kind of purplish amphiphilic cytoplasm. And number two, and very importantly, is if you look away from the big cells, look at the background. The background is loose, hypocellular, myxoid, and it has areas that resemble regular nodular fasciitis. Those kind of like those areas I showed earlier. Kind of spindled and stellate cells in a loose myxoid background. And you'll often have those pools of myxoid cystic change that I talk about in my nodular fasciitis video. Kind of what's happening here. There's like cystic breakdown in the substance of the lesion itself. And that's such a useful clue for everything in the kind of the fasciitis family of entities. And I think though that recognizing that loose myxoid background, the cystic change, the fasciitis-like spindle cells, when you see those and then you see large ganglion-like cells scattered throughout. I mean, look at how many big cells there are here, but they're all scattered in the midst of something that otherwise looks like a fasciitis and is growing at the place where a fasciitis would grow, down in the deep subcutis, right along the fascia level. And look, here's another example of one of those ganglion-like cells. Look at that. It's a beast, right? It's huge. It's got a massive nucleolus. So does this one over here. They look like ganglion cells, but if you stain them, they'll be negative for S100. Sometimes they stain with actin. They probably really are either fibroblasts or myofibroblasts, and they're definitely nothing to do with a neural cell, even though they look kind of like a neural cell. And so the keys, again, like I said, is recognizing the background. And then the other thing is the other general rules for nodular fasciitis. Usually nodular fasciitis is small, 3 or 4 centimeters at a max. So I think, like one of my mentors told me, if the lesion is much larger than 3 or 4 centimeters, you have to seriously reconsider, are you sure it's nodular fasciitis or are you sure it's proliferative fasciitis? It's not that it couldn't be a little bit bigger than that, but the bigger it gets, the more likely you are to be wrong. So here's a beautiful example of proliferative fasciitis, again, which is just a variant of nodular fasciitis in my opinion, and it's growing right along the fascia with this kind of linear fascial type pattern that we can see both in proliferative fasciitis and in nodular fasciitis. Okay, let's look at another example. And here's one where we're in the skin, actually. And so again, like I talk about in my nodular fasciitis video, fasciitis can grow in the subcutis and push up from the fascia into the subcutis and even sometimes into the dermis. It can grow along the fascia like we just saw, or it can grow down into the muscle sometimes. And we're going to see some examples like that in a minute. So here we have this proliferative process here in the kind of the deep dermis near the subcutis. There's a lot of hemorrhage and fibrin right here. There's this loose myxoid background, kind of bluish myxoid, or like dermatology residents like to use the word mucin. In pathology, we like to use the word myxoid, but all of it stands for basically glycosaminoglycans and hyaluronic acid, all those background gooey substances that fibroblasts secrete and make. And when we go closer, you can see them right there, the ganglion-like cells. So it's just really important to recognize that cells like this can exist in benign proliferations. And look, I mean, if you see some cells like that, you start thinking it looks like a Reed-Sternberg cell in Hodgkin's disease or something like that. First of all, I have never ever seen a case of real Hodgkin lymphoma in the skin. And I actually asked a very famous hematopathology expert recently if she had ever seen a case, and she said no, that she had not. So unless a patient has like end-stage Hodgkin lymphoma that's spread to the skin, I guess I would probably not accept something as being Hodgkin lymphoma in the skin. So if you see something in the skin that looks like a Reed-Sternberg cell, it's probably not. But you might think this is like CMV inclusions or a lot of different things. But recognize that fibroblasts and myofibroblasts can have this ganglion-like appearance. And again, look for the background that has that loose myxoid, spindle to stellate cells, that fasciitis-like appearance. I think it's one of the most important aspects of being a soft tissue pathologist, and also in any aspect of pathology, to recognize the varied appearances that reactive pattern myofibroblasts can have. And when I was Dr. Weiss's fellow, she told me one of the main goals of the fellowship was being able to separate reactive spindle cell lesions and other lesions that look like reactive ones from true tumors. And that sounds simple on the surface, but it's something that even in practice now I still struggle with on a regular basis. It can be hard in some cases. So this is a beautiful example of a background fasciitis area, and then we have those scattered ganglion-like cells. And if nodular fasciitis, if you have a couple ganglion-like cells, you can still just call it nodular fasciitis if you want. Calling it nodular fasciitis or proliferative fasciitis doesn't really matter for clinical purposes or treatment purposes. It matters more for us as pathologists to recognize, oh, hey, here's a weird variant of nodular fasciitis that looks super scary microscopically. Now, this same pattern of kind of reactive looking myofibroblasts with big ganglion-like cells can also occur deeper down in the muscle. And when that happens, we call it proliferative myositis. So that's why I'm grouping both proliferative fasciitis and proliferative myositis together here for the purposes of this video. And in the muscle, I think it looks particularly scary. And sometimes you can have actually bone formation around it. See, we have some metaplastic woven bone formation here. And so this kind of shows an overlap with another entity called Myositis Ossificans. You see these things all have this Myositis Fasciitis names in them, and they all have these overlapping, really exuberant, reactive pattern myofibroblasts and other reactive changes. So when you see that, you might think, oh my gosh, this is like osteosarcoma. Look, there's big cells. They're making osteoid and bone, but these are just big, plump osteoblasts that are kind of coming to this area and forming reactive metaplastic bone. So how do I help sort this out from, say, extraskeletal osteosarcoma? Well, if you look around at the cytology, you're going to get real freaked out because these cells are big and they're funny looking and atypical. And next time you see reactive bone formation at a known fracture site or a known site of surgery around a bone, go and look at the reactive osteoblasts as they're laying down new bone, and you'll be blown away by how wild and atypical reactive osteoblasts and also chondrocytes and chondroblasts that are growing new cartilage. Reactive bone and cartilage can look really, really wild and really scary if you don't have experience with it. The key here is not going to high power, it's going to low power. The one thing that stands out about this is you've got definitely a spindle cell, a kind of loose myxoid spindle cell proliferation here, but look what it's doing to the muscle. It's not blowing away the muscle and pushing it out of the way and making a big solid mass. It's intercalating between the muscle. All these little pink circles in here are individual skeletal muscle fibers. Look, if you don't believe me, let's go look. See, and even though they're in cross section, not longitudinal section, so you can't really see the striations, you know that this is skeletal muscle because it has peripheral nuclei, right? It's a little pinkish red bundle, and all the nuclei are around the outside of the cell. And so these are individual skeletal muscle fibers here, and each one is kind of invested in it and surrounded by what looks like bland spindle cells with a loose myxoid background. Looks just like fasciitis. So recognizing this, what we call kind of a quilt-like or patchwork pattern where there's reserved muscle and individual muscle fibers all scattered together with the background of spindled and stellate myofibroblasts, just like this here. That's the perfect way to recognize that what you're dealing with is probably one of these reactive or reactive-like processes like proliferative myositis or Myositis Ossificans. And again, I think that there's overlap between those. See, look here, this is, if you go back to my nodular fasciitis video, this is exactly what I'm talking about of what people call the tissue culture pattern of these kind of loose, stellate myofibroblasts that are kind of growing like a sheet of cells would grow in a tissue culture dish. But since many people in pathology have not ever cultured fibroblasts before, I never have, I think that I like the words loose and feathery to describe these areas. I think that resonates more with me as a visual clue. And then look what we have here. We have these big, huge ganglion-like cells again. So we have the ganglion-like cells, there's more ganglion-like cells, more ganglion-like cells. We have the loose, kind of feathery, tissue culture-y, nodular fasciitis-like background with scattered, extravasated red cells. And then we have, in this case, complicating it, we have the muscle involved, but the muscle is present in these kind of patchy-like areas and is not pushed out of the way. So most sarcomas, not all, there's some exceptions, but most sarcomas grow quickly enough that they push all the muscle out of the way. And what you have is a big mass of spindle cells, and all the background muscle is out to the periphery of the tumor, not in the midst of the tumor. Now, there's some exceptions, like I said, like myxofibrosarcoma, which often infiltrates adjacent tissue, dermatofibrosarcoma protuberans, DFSP, usually does not infiltrate muscle. Occasionally it does, but usually infiltrates fat with a kind of fat entrapping pattern. So it's not a perfect rule, but most sarcomas as a general rule will push muscle out of the way. So if you see a bunch of muscle scattered throughout a process and you're thinking about a sarcoma, stop and think really carefully to be sure that you're right. Because anytime I see this pattern, this patchy quilt-like pattern of muscle that's left in the midst of a spindle cell proliferation in the middle of a muscle, I always stop and think, could this be a reactive process? So this is a nice example of proliferative myositis. And oh, over here, we have even better ganglion-like cells. Look at these guys. They're out of control. I mean, just amazing. Huge cells with big open nuclei and big prominent nucleoli. They look like little eyeballs staring back at us out of of a sea of fasciitis-like background. So it's a beautiful example. And I think this is really, really nice. So this is a nice example of what I would call proliferative myositis. And again, I think of it as on a spectrum with proliferative fasciitis. These can sometimes get a little bit larger, especially Myositis Ossificans. I've seen those get actually quite large, and they have a real distinct radiographic appearance also, with a kind of shell of peripheral bone that shows up on imaging once the bone matures and picks up calcium. So in that setting, it's important to recognize, make sure that it correlates with the radiographic appearance as well. So this is really nice. And again, you got the skeletal muscle right there, caught up in the midst of it. Let's see if we can get the striations to stand out. Sometimes it's hard to get them on the video, and you can see the striations right here. Okay, and so the difference between proliferative fasciitis and Myositis Ossificans is that proliferative myositis and Myositis Ossificans is that if the lesion's in the muscle and it looks like this, as this patchy infiltrate of fasciitis-like stuff with ganglion-like cells, we usually will call that proliferative myositis. If, on the other hand, you have a lesion in the muscle that's replacing muscle with the fasciitis-like spindled myofibroblasts and not so many of these big ganglion-like cells, and then at the periphery is a shell of kind of this reactive woven bone like we see here, those are the lesions that I would usually call Myositis Ossificans. The distinction, though, is, again, this is more important for us as pathologists to recognize different patterns of benign reactive processes that look really scary. If I tell the clinician this is Myositis Ossificans or this is proliferative myositis, it doesn't matter. They're both benign and they're both going to have a good outcome. So the important thing is that we recognize microscopically, don't call this osteosarcoma or some other sarcoma because of these big, funny-looking ganglion-like cells. You don't want to make that mistake. So recognizing that the ganglion-like cells are scattered in a background that looks just like fasciitis, and that the muscle fibers are kind of intercalated here and left over and not pushed out of the way and destroyed like they would be in a normal sarcoma. Those are the keys to not overdiagnosing this as a sarcoma. Now, the problem is that these can be sometimes quite cellular, particularly in kids. You can have a lot of those ganglion-like cells and have a really hypercellular example of proliferative fasciitis or proliferative myositis. And I think that is really problematic sometimes and can look really scary. And those cases are ones that I've still struggled with even as a soft tissue pathologist. This case, I think, is one of my favorites because it really highlights an important point. Here we've got a bunch of blood and fibrin, bunch of hemorrhage. So hard to tell if this is a hemorrhagic tumor or what's going on here. You can see muscle fibers, but they're all dead. They're dead, and we know they're dead because they don't have any background nuclei. The nuclei are all wiped out. All we see is the ghosted outline of the individual muscle fibers. And then over here, we start seeing areas that are fairly cellular. I think there's a better area. I'll go find it. Ah, there it is. And here we have big, round, kind of epithelioid looking cells with big nucleoli, but they're like almost in a solid sheet. They're much more cellular than the previous example I showed you. And mitotic activity, I didn't mention this, but mitoses are totally normal and can be quite abundant in not only in nodular fasciitis, but also in proliferative fasciitis and proliferative myositis, Myositis Ossificans. All of these itis processes in the fascia and the fat and the skeletal muscle can have have a lot of mitotic activity. So seeing big cells like this and hypercellularity plus seeing a lot of mitoses, very scary, and it's easy to overdiagnose something like this as malignant. But look, going back to lower power, what do we have? We have retained skeletal muscle fibers. They're dying and broken down, but they're all intermingled with this background of ganglion-like cells. So that's one clue. Clue number two is that over here we have areas that are loose and spindled to stellate with kind of some feathery tissue culture-like stuff and a lot of extravasated erythrocytes. So this case was from a long time ago, but I remember it distinctly because I looked at it, I thought, well, it has the reactive fasciitis-like looking myxoid loose areas. So that would be a point towards benign proliferative fasciitis. It's got all of these entrapped, degenerating, in this case, dead, some of them, skeletal muscle fibers that are all mixed up in a kind of quilt-like or patchwork pattern with the big ganglion-like cells. But it's so cellular and it has mitotic activity. So I really had a lot of anxiety, but I really thought in my heart that diagnostically, I thought this really fits well for a real exuberant proliferative myositis. And then I called and talked to the surgeon, and they said, oh yeah, this patient was in a really bad car accident and had a big cut on their arm from where the glass cut through it, and this was actually just an open wound that we were debriding. We weren't worried about a tumor at all. This was 2 weeks after the car accident happened. So to me, this is a beautiful example because we don't have to wonder, well, were we right or not? We know that there was no tumor here. This was someone that had a really bad traumatic injury, and this is what happened when the muscle had a bad traumatic injury and had reactive reparative change around it. So I think this is a really great example because it shows just how exuberant this process can be, and we know by the clinical history that this is totally benign and reactive reparative change. There was no concern at all for a neoplasm clinically, and there was a good history of known trauma from a big wound during a motor vehicle accident. So really a great example of just how proliferative these can look. Let me show you one other example that's kind of like this to close out. Oh, let me clean the slide again. They get dirty so quickly. Okay, so here again, hopefully by now you're recognizing there's skeletal muscle. So even from low power, it's good to start picking up. There's fat, there's kind of myxoid spindled areas, there's skeletal muscle, all of it's kind of mingled together. And that kind of, there's not one central dominant mass here. And that should always make you stop and think, am I sure I'm having dealing with a neoplasm or a malignancy if I can't find one central area of mass? If all I see is kind of spindle cells and myxoid stuff intermingled with background tissue like fat and skeletal muscle, then I should really stop and question if I'm sure that what I'm dealing with is a sarcoma. Go into higher power, what do we see? We see loose tissue culture-like or feathery areas of spindle to stellate myofibroblasts, extravasated red blood cells or hemorrhage right here, which is another useful clue that people like for fasciitis. We can see the skeletal muscle fibers are entrapped in the midst of all this and scattered throughout. The stain on this slide is not particularly good, I apologize, but scattered throughout. We have some larger kind of ganglion-like cells in here that have big nucleoli. We also have some atrophic multinucleated skeletal muscle fibers. As skeletal muscle breaks down, all of the protein gets broken down in its cytoplasm, and the nuclei get closer together, and eventually they can overlap each other and really look like a big pleomorphic cell when in fact it's just a bunch of nuclei kind of crunched up. Here's more kind of ganglion-like cells. Let's see at higher power. Perfect. So this goes well with the pattern that we've seen in the other cases of proliferative myositis. But guess what? This was at the site of a bone fracture. So this was a soft tissue mass that was right next to a large fracture in a bone, and this was a couple of weeks after the fracture had occurred. So the question was, well, is this a sarcoma or something growing out of the bone, or is this a soft tissue sarcoma that grew into the bone? And in fact, it's not. This was just a fracture in an elderly person, and what we had was a secondary reactive proliferation of reactive myofibroblasts occurring in the skeletal muscle and soft tissue directly adjacent to the bone. The reason I'm pointing this out is I've seen seen cases like this before where this pattern was mistaken as sarcoma next to a fracture site. And I've also seen cases where there was a bone neoplasm, like in one case I saw a myeloma, a large myeloma that had caused a fracture in a bone, and adjacent to it there was such abundant reactive change that initially it was thought to maybe be a sarcoma, and it was only on closer inspection that it was actually seen that this stuff was all reactive, and in the background there was a clonal plasma cell neoplasm. So again, recognizing this reactive pattern of myofibroblasts is so incredibly important as pathologists. Even if you're not sure, if you recognize it and think it might be reactive, you can always get a consult or get someone else to help you, but it's good to know when to stop and think, this might be reactive, this might be fasciitis or a proliferative reactive fasciitis-like process instead of a soft tissue neoplasm. And I think that is such an important life skill, basically, in the field of pathology. And hopefully you agree.